Thank you, Anaga, for inviting me for your course. Thank you, Kumar, for making my job a little easier. So, just to outline my talk, I'm just going to basically enumerate some of the common mistakes that we carry out preoperatively and intraoperatively during toric IOL surgery. We look at ways and means of how to prevent these mistakes from happening. And as we go along, and once we realize you've done your surgery, in the end, we'll conclude by trying to repair some of the mistakes we do. So, to begin with, do we really make serious mistakes in toric IOL surgery? I have not seen a more forgiving surgery when it comes to monofocal torics. If it comes to multifocal toric, of course, it's a different thing altogether. But one thing that is very sure is that patients' dissatisfaction with this procedure or with the doctor performing it is extremely unlikely. So we actually begin on a good ground. So what are the common mistakes we do? The first mistake that we very often do is choose a toric IOL when it doesn't need to be done in the first place. You make errors in biometry, you can have errors in execution and errors in calculation. Sorry, errors in calculation followed by errors in thing. So look at the topography in each and every case. So if you have a regular astigmatism, which shows a symmetrical bow tie, this is an ideal case for a toric IOL. But sometimes you get a case like this where there is an asymmetric bow tie. This is not a very ideal case, but you may still escape. But what happens when you get a case like this? Now, this is not a case which is suitable for a toric IOL. Errors in biometry. The first thing that we have to do is that we must do the biometry before we put in any local anesthetic in the eye to take the eye pressure or before we put any dilating drops. Have a close look at the ocular surface. In fact, if there is a patient who has an obvious ocular surface disorder, this biometry should be postponed till this thing can be done. And use a keratometer that measures the K values within the central 3 millimeter zone. If you have a keratometer which measures outside, like an autokeratometer, this is not likely to be used. And once you have done the biometry, immediately assess the tear film by doing the T-BUT and the Schirmer's 2 test, and look on the slit lamp whether there are any clinical syndromes like a punctate keratopathy or a meibomian gland dysfunction, which may render this case unsuitable for the biometry itself. Now, when it comes to biometry, as all my previous predecessors have explained, there is no biometer which is as good as an optical biometer. That is the first thing that you must have when you're doing toric IOLs. And if it comes to even on the optical biometer, it's very important that you look at the patient from the side as well as from the behind to see whether there is a head tilt, from the side to make sure that the lateral canthus of the patient is aligned with the reference mark on the machine instrument that you're doing. And even after you've done that, you make sure that the patient is looking straight ahead, because if the patient is looking upwards and not at the fixation light, this is the kind of reading that you'll get, which is not suitable for your case. So K readings on multiple devices are to be encouraged. I mean, don't just stick to one instrument, take measurements from several instruments. And while these instruments might differ, there may be some pattern that might emerge, which might be clear for you. A lack of consistency amongst all instruments is a red flag. You have to keep on looking at this and probably improve the ocular surface and take the readings again. And if you have multiple readings, you can also integrate all these readings on the Barrett toric calculator. The posterior corneal astigmatism should be measured whenever you have either a Scheimpflug device or you have a IOL Master 700 TK, which looks at both the anterior and posterior curvature. Why this is important? Because the posterior corneal astigmatism I've seen can vary right from a 0.1 to 0.7 diopters against the rule. Remember that the Barrett toric calculator assumes a 0.3. So if you have a 0.7, you need to tweak your IOL power. So therefore, if you can have a look at the posterior corneal astigmatism in all cases, it's a big help. Errors in calculation. A very, very common mistake done by all optometrists is to have a wrong entry. Sometimes there is a flipping of the steep and flat axis. They're so used to saying things as K1 and K2. Now K1 may be 45 and K2 may be 44. So in that case, you know that this is against the rule astigmatism and this will be flipped in exactly the opposite. Incorrect surgical induced astigmatism is a very common mistake. You have planning for a certain meridian and you're planning for a certain SIA, and you probably put that incision, as I'll show you an example, superiorly, or if it's a longer incision, then of course the SIA would change. And of course, do not use a calculator that does not consider the posterior corneal astigmatism. That's a given thing. Now I'll show you one simple example. This is when the Toric calculators came long back in 2007 when I implanted my first one. And you can see that the option given to you is a T4 model with the anticipated residual astigmatism of 0.45. So now you don't go strictly by the calculator, use your common sense. If you use a T5, the anticipated residual astigmatism will be less. This is because these calculators at that time spoke only in terms of positive residual astigmatism. Now switch back to 2023. Now we all use the Toric calculator. Now I'll show you this example. I always operate a 2.2 millimeter incision in the temporal zone, and my surgically induced astigmatism is 0.1. Now in this particular case, what happened, there was a fleshy pterygium on the temporal quadrant, and I was not going to. So I just told my my optometrist that I will be operating superiorly. See what she has done? She's put the incision at 100 degrees, which is comfortable for me, but she put the incision SI as 0.1. Now there's no way that a superior incision will even give you a centroid value of 0.1 with a 2.2 millimeter, except when it is done in the temporal quadrant. So this is obviously a mistake that has happened. So, and there is another example where I want to show you, if you can read from there, the options given by the calculator was a 22.5 diopter lens for a minus 0.07 spherical equivalent. For a SN682, the residual was plus 0.16 at 176. And for the SN6T3 model, it was plus 0.17 at 86 degrees. Now, which one would I choose? The obvious answer to this question is that if I were to put in a monofocal toric, I'd probably put in the first option, because a little bit of residual against the rule astigmatism will help to give this patient a good depth of focus. But on the other hand, if I'm going to put in a multifocal toric, my option should be T3, where I will be converting this patient to with the rule astigmatism, so that even if this astigmatism decays with time, this will be helpful for the patient. Errors in execution. Errors in execution come because of incorrect reference marking, because of intraoperative complications, because of incorrect alignment and rotation of the IOL post-op. So one very important tip for those who are making markings is that probably do this in the sitting position. Use a speculum to keep the lids apart. So you're not holding your lids apart to make those marks over there. The speculum put in also dries the cornea, which is very helpful for putting those marks on the cornea. The peripheral cornea should be indented and inked rather than the conjunctiva, which is mobile at the limbus. And after you've done this, you must verify this on the slit lamp, like you can see in this case, before the patient is moved into the OT. So this is the preoperative thing. Make sure you put the marks, make sure that when you make the slit lamp vertical and horizontal, it is aligned with those marks. If it's not aligned with those marks, then you go in and make that little change. You rotate the slit lamp, see how many degrees of rotation has occurred even where you are marked. Don't assume that your mark will be perfect. Or you can use this particular app, which is the iToric, Dr. Patwaran's. You have made those marks over there, and then you use the gyroscope of your ordinary mobile phone, which shows that your marks are not aligned. You now know how you have to place the lens, because he also provides you where you need to put the lens. If you're using a markerless system like the Varion, you have to make sure that the picture that you have chosen for your reference marking should be with the eyes open full, not with the eyelashes covering the cornea and where the blood vessels are indistinct. This is another source of error which comes in. Intraoperatively, in case you have eventful surgery, there is a posterior capsular rent, there's a vitreous disturbance, or there is a zone dial, ask yourself whether you want to put the toric IOL over there. And one other important thing which completely throws the surgically induced astigmatism out of gear is a corneal wound burn, which might sometimes happen with a hard cataract. During surgery, you have to make sure that whether you use a markerless system or you use the axis marker, make sure that at the end of the surgery, you have aligned those marks very well, as you can see over here. And do this after you have aspirated the visco under the IOL. That's even more important. Rotation of the IOL post-op always happens because you have left some visco behind. So make sure that you have aspirated the visco very well. As soon as the surgery is over, you come outside and again put the patient on the slit lamp to make sure whether you have got it right. Because nothing is as good as a slit lamp for giving you the accuracy of your IOL placement. In case the rotation is more than 5 degrees, it's your business to go back again and put this thing properly in the bag. Now that we have enumerated the complications and ways to prevent them, Let us look at what happens once the surgery is done. Look at the patient's uncorrected visual acuity. The most important thing is not 20/20, but whether the patient is 20 happy. If the patient is 20 happy, I don't think you need to do anything further, because a small amount of residual astigmatism is beneficial, especially in those people who you're putting in a monofocal toric. Which cases to treat? I'll just take 1 or 2 minutes. Yeah. Which cases to treat? So if those cases is a multifocal toric, these are my low threshold cases. These are cases where I will go in and intervene. So if the patient is a multifocal toric, has got an oblique axis, has got a residual hyperopic or a mixed astigmatism, if the patient's best corrected visual acuity is 6.5, then this patient knows, even if the patient's unaided vision is 6.9, he knows that he has a potential for getting better vision. So if you're, even if it's 6.9, don't give it up. You see what is the patient's best corrected vision. Look at what the surgically induced astigmatism was chosen. Maybe it was incorrectly chosen. Or when monovision is the goal. Monovision is again an area where you got to be spot on. So if you're not spot on, you got to go back. What are cases where there is a high level of tolerance? It's just the opposite. Monofocal torics, where the astigmatic axes are horizontal or vertical, when the residual astigmatism is myopic, and where the best corrected visual acuity for whatever reason is 6x or less. Analyze your refractive error. You have to do the post-op refraction, look at the post-op K readings, look at the post-op axial length reading, look at the post-op ACD, again very important, as Kumar just told you, and look at the post-op IOL power calculation. Now, if the IOL power calculated is correct, you just go back to the toric calculator, put the post-op Ks as a pre-op K, induce the surgically induced astigmatism if you're gone in by the Barrett toric calculator, and simply dial the lens to the new axis as suggested by the calculator or as suggested by the post-op cylinder. If the post-op K is as expected, then these are the possibilities. Either the residual cylinder or the sphere was high in the calculations, the IOL rotated in the immediate post-op period, or you did not place the IOL in the first place in the correct axis, there was a significant PCA which was overlooked, or there was a combination of these errors. If the post-op K is not as expected, then there was an error primarily in your data calculation. There was an error in the data input. Maybe there was a flipping of the axis. There was an unexpected SIA, as I told you, due to wound burn, due to unexpected surgical complications, or there was a complication of the error. So how do you manage the residual refractive error? In case of a flipped axis, just rotate the IOL by 90 degrees and you're back in the business again. In case the spherical equivalent is 0, LRI can be attempted. For all other errors, either you rotate the IOL, or you do an IOL exchange, or you piggyback this IOL as suggested by the Barrett RX formula. One more wonderful armamentarium in the Barrett suite is the Barrett RX formula. So you put in the post-op case with the major and minor meridians along the axis, put in the pre-op case, put in the IOL power model which was put in this case T4 model was, so you input all these things, put in again your surgically induced astigmatism, your wound incision, and the output given to you that probably you should have used a T5 in the first place and not a T4. He also gives you a kind of a graph where you can know that if your patient was placed at 90 degrees, if you put that axis at 20 degrees, you are probably going to get the least minimum residual astigmatism. If nothing else works, then in those patients where the patients don't want further interventions, or there is a problem with the IOL stability because of a zonular dialysis or some other problem, then in that case you can always do a LASIK to correct it as a bioptic procedure. And if nothing else works, then glasses is always an option. So do consider that. Thank you so much.